from the waist down. We did have a change in her medication. I'm sorry, not in her medication, but in her viral load. They done another lab on 6/22. So where what you have is 2,140,000. It is, as of 6/22, 2,470,000. So does anybody have any question about her?
Thank you so much, Alice. And I'm just scrolling down here a little bit more so some more folks can see the additional lab results here. Did anyone have any comments, thoughts, or questions about the case? I'm more than happy to pull it up again if you would like to review it. Feel free to unmute or chat in.
Hey, Alice, this is Kaylee. Is there any liver imaging on her?
No, ma'am.
And then are you able to, just because I don't have it in front of me, under her serum fibrosis marker, it says 0.38. Do you have the conversion as to what stage?
She is F0.
Okay. I just want to make sure because I always have to pull up that table. So I guess, I mean, if anybody else wants to chime in, that's fine. If you're planning on treating her, you know, I mean, she has several options. Did Dr. Bailey mention anything about which preference she was leaning towards?
He was leaning towards the Mavorite.
Okay. Okay. The only thing I can think of with the Mavorite would be the atorvastatin that she's taking.
Yeah,
Yeah, you could stop that if she's able to. I mean, from her health history, it looks like I see hypertension, diabetes, the COPD, the neuropathy, and then the paralysis and the osteo you mentioned. If she doesn't have any history of you know, cardiac issues, I guess, in the form of stroke or MI in the past, you could probably just hold that if it's just for hyperlipidemia. And you could do the Mavorite. The only other interaction I see, but that's going to be with any of the Hep C agents, is the Xarelto. And there's not any indication it wouldn't need to be stopped or adjusted. She would just need to be monitoring for signs and symptoms of bleeding because it could increase the Xarelto. So just be monitoring for that. But really, you know, the Mavorite for 8 weeks is going to be the shortest treatment option. If she feels like she's a good candidate and she's going to be compliant with treatment, I probably would still snag an ultrasound on her at some point. I don't feel like it necessarily needs to be done before she would start treatment, or if she has any abdominal imaging. It sounds like she's got a lot of health issues. So maybe in the recent past, she's had a CT of her abdomen or some kind of liver picture, just to make sure there's not any tissue changes. Even though her fibrosis level is reassuring, I would still get an imaging of her liver. But you know, if she feels like she's in a good place to get her started on treatment, then you wouldn't necessarily have to get that imaging before she started.
Okay, thank you.
Sure. Any questions about her otherwise? And I think just for the group too, I mean, the 4 treatment options for her genotype would be Mavorite, Epclusa, Harvoni, and Zepatier. The Zepatier, it's with genotype 1A, you'd have to get that NS5A resistance testing at baseline. But with the other 3 agents, you wouldn't necessarily. Harvoni is not typically preferred on Medicaid's formulary, but depending on her Medicare Part D plan, it may be an option for her. Since her viral load is less than 6 million, that could potentially be 8 weeks, as long as there's not any cirrhosis or any advanced liver disease on her imaging. But Mavorite and Epclusa are both the 2 pan-genotypic agents, so those are kind of the ones that we shoot for initially.
Okay, thank you.
The regular, yeah, This is Tammy, and I think I missed the history of what how she got Hep C.
Let me find it on my paper. She had unprofessional tattoos, and she also had, let's see here. Yeah, it was the tattoos, and I'm sorry, her fibrosis score was an F1 instead of F0.
Okay, that's fine. That wouldn't change the management. Thank you.
Okay.
Hey, this is John. Just a couple of things. Yeah, I'm glad you corrected that. That fibrosis score, according to Google, is F1, F2 borderline. The only point I wanted to make on this lady before you launch into treatment is she does not sound like a healthy human. And as such, anybody with a bedridden and history of osteo their spine and a bunch of other whatnot is at high risk of hospitalization at any point in their life. So this isn't something that you'd pause her treatment or not treat her for, but she's the person to have a really good communication with about having a plan in case she gets hospitalized for someone to bring her medicine to her in the hospital. As we've talked about numerous times, these medicines are not on hospital formularies. If you get hospitalized during your treatment course, it is one of the more common reasons we see for treatment interruption and therefore treatment failure. So would really, really, really want to have her have a contingency plan that if she ended up in the hospital for X, Y, or Z, that someone could bring her meds during treatment. The other point I was going to make was her viral load, you mentioned the change over time. Remember that when we talk about significant changes of viral loads, we often talk about multi-log differences. So for all intents and purposes, those two viral loads are the same, those 2 point whatever million. And remember, viral load doesn't matter a ton. In hepatitis C, for the learners on the call, you can have chronic liver disease develop even with low viral loads. And you can have people with high viral loads without chronic liver disease. So the viral load is really not terribly helpful outside of trending for acute resolution during and after acute hepatitis or evaluating response to treatment. Otherwise, it's almost viewed as a qualitative measure, present or not present outside of those areas.
Thank you.
Thanks, Dr. Gilfus. That really good points that you brought up. And then just the other point with the viral load is just if you're going to use Harvoni, if that would be on her formulary, then hers isn't over 6 million, but that's the other kind of caveat when we would need the viral load, the numeric value would matter is a shortened course of Harvoni, and certain patient populations would, for 8-week course, it would have to be less than 6 million.
Thank you all so much for the feedback and recommendations. Alice, were there any other questions you had about the case that you wanted to address?
No, ma'am. Thank you.
Thank you so much for the awesome case presentation. Alrighty, Jess, I have your case ready to go as well. I'll share my screen and just let me know when you'd like me to scroll up or down.
All right. So I have a 37-year-old female that came in. Her blood pressure was 120/60, heart rate of 72. Otherwise, her exam was unremarkable. So for her history, she was diagnosed with hepatitis C when she was pregnant in 2009. She does have some risk factors, including IV drug use and intranasal drug use from 2003 to 2011. She's had tattoos done professionally and non-professionally. Her most recent tattoo is 5 years ago, and she was incarcerated in 2009. She doesn't drink alcohol. She said she's been clean from all drugs for 10 years, and she's currently in a Suboxone program. She did seek treatment for hepatitis C in the past, but it was before the fibrosis restriction was removed for Medicaid. So her comorbidities include mild intermittent asthma, depression, and anxiety. For medication, she is on Suboxone, Buspar 10 milligrams TID, lamotrigine 20 BID, and albuterol as needed. She doesn't need it very frequently. For hepatitis vaccinations, she is immune to hepatitis A, confirmed by lab, and she is not immune to hepatitis B. She has gotten her first vaccine at our visit in May. She is 5 feet tall, has a BMI of 36. Lab wise, her platelets are 328. Her creatinine was normal at 0.77. PT and INR, or prothrombin time is 10.9, INR is 0.97. Her albumin was good at 4, AST was 86, ALT 134. Her alk phos was 115. Her APRI was 0.475. Her CTP score was 5, which was class A. Her MELD score was 6. I did check her vitamin D. It was 23, a little bit low. Her HIV test was negative. She has genotype 1, and her viral load is 1.5 million. And she has F0 for fibrosis marker. So based on her insurance being West Virginia Medicaid in the formulary, I was considering Mavorite or Epclusa for her treatment. And another question that I had was on the prior auth form, it makes you check whether it says immune to hepatitis A and immune to hepatitis B. So I didn't know if she needed to complete the series for hepatitis B vaccine or prove immunity before we could start that treatment, or if I could just write underneath like started vaccination series.
Thank you so much. Awesome case presentation. Did anyone have any clarifying questions for Jess before we get into any of the recommendations? All right, any thoughts, comments, or recommendations for Jess? Feel free to unmute or chat in.
Hey, this is Kaylee. I'll let the fellows make any recommendations if they have any suggestions first. If not, then we can chime in.
We don't bite, we're nice, I promise.
All right, well, I guess I'll talk, but if anybody wants to interrupt me, please, because I don't like hearing myself talk all the time. Thanks, Jessica. I appreciate your case. I like how you do the timeline of the exposure history. That's always really important. So thanks for putting those date ranges, because that's helpful. But she seems like she's in a great place, and certainly it's frustrating that she was denied treatment in the past because of her lack of fibrosis, but I don't think she's going to have any problem with treatment now. In regards to your questions about the Hep B series, if you just write it down, like you said, you can write down that she started the series and then put the date that she got her first vaccine. If she doesn't have to have the full series completed, but sometimes they'll want to know that she's got an appointment scheduled for the next injection so that she's truly completing it. So if you can just write, what date she started it on. And then with her insurance, Mavorite and Epclusa, they're both the preferred agent. So there's not any preference. The one thing I would point out would be what her sexual activity is, and if she's on any kind of contraception, since she's still childbearing age. Mavorite it doesn't look like that's on her med list, but Mavorite can interact with any kind of estradiol, ethinyl estradiol containing contraceptive. So if she, is planning to be on anything, it would have to be progesterone only or some alternative form, or I would go ahead and go with Epclusa. But definitely make sure you have a negative pregnancy screen before she would start treatment, just because there's not anything currently approved with pregnancy. Okay. And then I would still replace her vitamin D if it's not already. Just with anybody with kind of chronic liver disease, including hepatitis, we like to keep it above 40. So even though her level by the parameters isn't low, I would still opt to give her a weekly course, 50,000 units a week, for 12 weeks, and then she can just take an over-the-counter supplementation after that.
Okay. Thank you.
Thanks so much.
Thank you, Kaylee. Any other comments, recommendations, or feedback?
Just a comment. Hey, I was going to say the same thing that Kaylee did. This is John. Sorry. Love how you quantify the potential date range of exposure. You know, she was diagnosed in 2009, and but she is somebody whose risk factors go back all the way till the millennial turn. So she could be dealing with about 20 years of infection. And just to review natural history, you know, she's one of the lucky ones, apparently, dealing with maybe 15 to 20 years of infection, and doesn't seem to have significant chronic liver disease. So remember, that's about 1 in 3 of people after 20 some odd years still will not have any chronic liver disease. So that's good. She's lucky. Big picture, what that means both for this case and the prior case is after you treat these people, they will not need long-term HCC screening. So remember, as long as you don't have significant fibrosis after you're treated, you're done. The only thing to educate them on is risk of reinfection is real, and that antibody will persist lifelong but is not protective. So just education, stuff like that, but great job, and concur with Kaylee's advice 100%.
Thanks so much, Dr. Gilfus. Jessica, did you have any other questions about the case or anything else you wanted to discuss with the group?
I don't think so. Thank you.
Absolutely. Alrighty. Well, thank you both, Alice and Jess, for the awesome case presentations. We really appreciate your time, and you both did an awesome job, so thank you. Alrighty, Carolyn, I'll pull up your didactic for you and just let me know when you'd like me to advance your slides. Thank you.
Thanks, Mitra. And you can go ahead and advance. And I'm probably going to go through these first few rather quickly. I think it's, you know, everybody's probably familiar with it. But hey, again, everyone, I'm so thankful to Mitra for asking me to come back and do a little HIV education for you today. And I chose to do an update on women and HIV. And if you have any questions or any comments for me, just drop them in the chat and we'll address them when I'm done. Okay, next. So just looking at diagnoses up to 2018, you can see there's around 3,800 diagnoses or rates of HIV infection among adults and adolescents. Next. And just keep on going. Race and ethnicity. We can see that HIV continues to affect and infect African Americans and other minorities disproportionately as compared to white people in the United States. So this is pretty interesting, and this is something from around 2017. So unfortunately, what we see about regarding HIV infection, and especially new infections in the US, is that our minorities are at greater risk for acquiring HIV. And most especially young Black gay men really face the most severe burden of HIV among the Black population. So if you look at the US population, around 12%, but as of 2017, minorities were around 44% of new infections. So what that means is it means several things. There may be a lack of access to care for this population. There can be some cultural factors associated with, getting tested for HIV, transportation issues, so many factors that really we've been working on to try to help improve what we're seeing. Unfortunately, unless something is done and drastically done, at some point, 1 in 16 Black men will be diagnosed and 1 in 32 Black women will be diagnosed with HIV, which is an astounding statistic to me. Next. So what's going on in West Virginia? And this is only from 2017. I apologize, but this is the most recent data that can be pulled up from the state health department's epi data on HIV in West Virginia. So regarding HIV itself, there are around 1,800 persons living with HIV. And you can see by gender, unfortunately, in West Virginia, we have many people who receive an AIDS diagnosis within about 3 to 12 months after they've been diagnosed with HIV. And so what that means is they've been living a very long time with HIV without it being diagnosed. And so that affects patient outcomes. When somebody is living with HIV, but they have progressed to having an AIDS diagnosis, although we can get them on therapy, it's much more difficult to kind of restore and reconstitute that immune system. So we really want to do a better job in diagnosing people with HIV earlier on in the disease process because that does lead to better patient outcomes. Next. And this is the exposure category again, gay men, and that the MSM is men who have sex with men, are a little over half. Heterosexual contact is remaining stagnant at about 18% in West Virginia. Next. Now for females specifically, from 2012 to 2016, there were 20% of new infections. And then 22% of persons living with HIV at the end of 2016 were women. You can see the median age was about 38, mostly white. But again, there is a race disparity because if you look at population of Blacks in West Virginia, they're about 3% of the population, but around 13 to 16% of new HIV infections. Transmission category, please look at this one, 71% heterosexual for women. And what that means is that she is more likely to acquire HIV from a positive male partner related to her vaginal vault. If she is on the receiving end and he ejaculates, he's ejaculating 2 to 3 teaspoons of semen, which is an infectious fluid, into her vaginal vault. And, you know, that's a very large surface area. So she's more at risk for acquiring HIV from him than he is from her. Next. So let's look just generally at HIV in females. Next. So this is WHO data from 2020, and looking at the column on the left, around 38 million total people are living with HIV on a global level. If you go down a couple of blocks, around 19 million of those are women. And then going over to the next column, new infections, about 1.5 million. And around 670,000 of those are among women with new infections in 2020. Next. So transmission category, again, women are acquiring their HIV from an infected male partner through heterosexual unprotected sex. That's about 85%. Injection drug use among women, pretty small, about 15%. So again, it's mostly heterosexual unprotected sex is the way she is acquiring her HIV. Next. And then by race and ethnicity, if you look at this graphic, The green is the female population, and the purple is diagnoses of HIV infection. And you're looking at it by race. Look at Black and African American women. In 2018, it was about 58% compared to around 21% for women, for white women. So again, that it is glaringly in your face in this slide about the disparity of HIV infection among minorities in this country. Next. In transmission category again, look at this, 92% heterosexual contact among African American women in the United States. And again, that deals with some health indicators and geography, access or lack of access to care, cultural factors and cultural differences, the fact that many partners of many women, Black women in the United States, have been in the prison system at some point in their lives, which does increase her risk for acquiring HIV. Next. So unfortunately, about 1 in 4 persons in the United States living with HIV is female. Only about half of the women living with HIV have viral suppression, which means they have a viral load that is undetectable, less than 20 copies of virus per 1 cc of blood. So half of the women overall in the United States living with HIV are virally suppressed, and that is not a good statistic. Next. So women and girls living with HIV regarding care. So of the 88% who have received an HIV diagnosis, 64% have received care. That's a pretty low number. Only 50% retained in care, and less than half are virally suppressed. Next. Okay, I should just remove that. Next, so what are some circumstances that place us as women at higher risk? Well, just having sex with a male partner. I already told you some information about the makeup of our vagina and the vaginal vault. We are more likely to acquire HIV from an infected male partner. Having more than one partner. So if you guys are doing sexual histories for your patients, that's something you might want to ask them. How many partners do you have? Because the more partners that we have, the increase is the risk for us acquiring HIV. And she may not know if her partner has a risk, because they may never have that conversation. And he may not be monogamous, and she is. And not want to disclose. And then risk related to the various sex acts that we perform. So the least risky act of sex related to transmission of HIV is unprotected oral sex. So that is not 100% because there are some factors that are involved with maybe some bad oral hygiene. The next riskiest is unprotected vaginal sex, and the most risky is unprotected anal sex. And many people, including us as healthcare providers, still think that it's just gay men that enjoy anal sex, but heterosexual couples enjoy anal sex, and so do adolescent females. For the adolescent, it's a way to have sex but not get pregnant. For heterosexual couples, you don't have to wear a condom. Tearing of the rectal lining is very common during every single act of anal sex because that lining is so thin and so very well populated with, blood vessels. So any small tear like that is a beautiful portal of entry for virus. So here's another reason that you might want to talk about using condoms for anal sex. And then, of course, the presence of STDs or STIs can increase our risk for acquisition and transmission of HIV. If we are, if we are persons with substance use disorder, and we are sharing needles, that is a portal of entry for HIV. That is the second most common way to acquire or transmit HIV in the US. The first is unprotected sex. The second is needle sharing. Unfortunately, what we're seeing in West Virginia regarding our harm reduction programs are the threatened closure of some of these programs. And if not closure, very restrictive in how they're able to operate. And this is pretty new from this year. And also, is she in a relationship that may have intimate partner violence that is very problematic regarding HIV and her lack of control in her relationship with them. Next, please. Other circumstances is the anatomy, which we talked about already. You all know that any substance use disorder can lead to risky behavior, including unprotected sex, not knowing what your partner's status is, or needle sharing. Women are more likely to be victims of sexual abuse, so they're more likely, if they have a history of this, to engage in high-risk behaviors like exchanging sex for money or drugs, having more than one partner, and having sex with a partner who is physically abusive when asked to use a condom. And I'll bet you $1 that you all have patients in your practices that you see who are victims of abuse. And then being pregnant, most women who are pregnant do not use a condom, because in women's eyes, even today, they think of condom use as a form of birth control, which it is, but it's also harm reduction for HIV and other STIs. Next. Now, this is a really very interesting, I think. It's looking at a woman's risk of acquiring HIV during and after pregnancy. So this study is being done in Eastern and Southern Africa, the Partners PrEP study and the Partners in Prevention HCV HIV transmission study. So the background of this is they wanted to understand the risk of HIV acquisition during pregnancy and during the postpartum period. And, looking at the results, it can help inform prevention strategies for women on a global level. So there were almost 2,800 serodiscordant couples, and serodiscordant means that one partner is HIV positive and the other partner is HIV negative. So they were enrolled in either of two HIV prevention trials in Africa. So women underwent HIV and pregnancy testing either on a monthly basis or a quarterly basis, depending on which arm or which trial they were enrolled in. And each month, couples reported how frequently they had had sex and whether they used condoms or not. Next. So during the course of the study, 686 pregnancies were identified and there were 82 incident HIV infections. Adjusting for condom use, PrEP use, age, and HIV viral load, the researchers calculated a probability of 1.05 HIV transmissions per 1,000 sex acts when she was not pregnant. And as we go on, they calculated 2.19 transmissions per 1,000 sex acts during the first 13 weeks. So that's the first trimester of pregnancy. The probability of HIV transmission in late pregnancy, which was 14 weeks to delivery, did rise slightly to almost 3 per 1,000 sex acts. And then rather startlingly, there were around 4 HIV transmissions per 1,000 in the first 6 months, postpartum months. So what exactly that does it mean? We really, at this point in time, don't know. Is it some kind of physiological change? Is it something that they're doing postpartally? Are they not using condoms? We really just don't know yet. More research needs to be done, and these are ongoing. Next. So regarding HIV prevention for females, everybody knows about the male external condom, and there is an internal condom for that is used as well. And I don't remember if I included a picture, but it looks, it's kind of a big condom. It looks like somewhat like a male condom, but it's big. I would say, if you can see my hand, it's about this large in diameter and probably about 6 to 7 inches in length. It does have a ring that is inside. And so in order for women to use this internal condom, they have to squeeze that ring together, like they would squeeze a diaphragm together, and insert that up into the vaginal canal and against the cervix. And because it's larger than the male external condom, it offers some protection because it lays and covers the labia in that area. So internal condoms, and they're actually a little bit expensive. I would say if you were to order them online, they may run between $2 and $4 a piece. More European women will use these as compared to women in the United States. Could be just a lack of knowledge of providers on that type of condom that's available, and her lack of knowledge that is available as well. Doing testing and counseling for HIV and other STIs is a prevention measure for HIV disease. And this is interesting, voluntary male circumcision, which does last a lifetime. So in adult men, the foreskin of the penis has Langerhans cells, and those cells have an affinity for HIV. There is a HIV receptor site on those. And so by removing the foreskin, essentially you're kind of removing that risk for him acquiring HIV. So it has a reduced risk by about 60%. And this is a very key prevention intervention in mostly Eastern and Southern Africa that has very high HIV prevalence. We do see some of it in the United States, although it's not one of those prevention measures in the toolbox for HIV that's being used often. And then, of course, harm reduction for persons with substance use disorder, having access to clean syringes and access to linkage to care, to medical services, to social services, all very important as part of those harm reduction packages that we see around the United States and in West Virginia. Of course, prevention for females does include PrEP, pre-exposure prophylaxis, treatment as prevention. This is a big one, and essentially this came from the START study, S-T-A-R-T, Strategic Timing of Antiretroviral Therapy, where they found that just throwing people on antiretroviral therapy, no matter what their CD4 count was, whether it was high or low, led to better patient outcomes regarding progression of HIV or not. And then we have the U =U campaign, which is undetectable equals untransmittable. And that kind of morphed out of the treatment as prevention tactic. Next, please. More prevention, be monogamous if at all possible, be faithful. And again, you know, yay for her if she is faithful, but what is her partner doing? And those are things that we need to ask regarding prevention for her. Limiting the number of sex partners, and then, you know, advising about douching. We as women really don't need to douche because our bodies do a pretty good job of keeping our vaginal area clean. I know people like my mother, she's 88, she used to douche. I remember that crazy old bag hanging in the shower that she would use. You know, it really does remove some of the normal vaginal bacteria that's protective. So by removing that increases her risk of acquiring HIV infection. So women really just don't need to douche, and that is a good teaching moment. Next. And then we did talk about PrEP. You know, PrEP uptake in women is pretty low. Kaylee is the PrEP expert in this group because she has that awesome clinic. But there are a lot of barriers for women's access to PrEP. It's their lack of knowledge about PrEP itself, lack of knowledge about HIV, and their own knowledge of their own risk perception. Intimate partner violence, again, is a barrier to PrEP use. Identifying women who may benefit for PrEP is, you know, something that we probably could do better at as healthcare professionals. And then there's provider bias as well. That's based on race, social class, sexual behaviors that might hinder communication about HIV risk and PrEP. The high costs that are associated with PrEP, that's really not true anymore. PrEP is usually covered by insurance as well as state insurance. And then a lack of resources and infrastructure to provide women PrEP in rural settings. Next. And this is just a PrEP to need ratio. So PrEP use among women 3 times lower than among men, indicating that women are not using PrEP relative to their prevention need. And this is compares male and female in 2017. Next. So how can we increase PrEP uptake? And Kaylee, if you have anything to say, if you're still here, please just chime in. So how do we do this? How can we increase PrEP uptake in women? Developing handouts or pocket guides or those kind of tools that are culturally appropriate materials for women to help increase her knowledge, to increase clinicians' PrEP knowledge, and equip them with the skills to be able to cultivate an interaction that can help with decision making. And we still do need research to identify what the best practices are for identifying women who might benefit from PrEP. Next. And U equal U, that's the undetectable equals untransmittable. So essentially it's when somebody is identified as living with HIV through testing, we want to link them to care. We want to get them on antiretroviral therapy, keep them in care, get their viral load undetectable. If they have an undetectable viral load, they will not transmit their HIV during a sexual encounter with a partner. So U equal U, undetectable equals untransmittable. So if you have women that you're caring for who are HIV positive, the end goal is to get their viral load undetectable so they can't transmit. Next. And we can go ahead with this and go ahead. And go ahead one more. And again, it's really, this is a scientific, evidence-based prevention model for HIV, the treatment as prevention and the U=U campaign. And this campaign is now in, I'm going to say 90 countries and over 600 clinical settings on a global level. Next. And I do believe I talked about that already. Next. So a little bit more about undetectable equals untransmittable. It really helped to transmit the lives of persons living with HIV, their social life, their sexual life, and also their reproductive lives, because women who live with HIV want to have babies. It helps partners be in a relationship without fear of transmitting HIV. Why is that? Because if our viral loads are undetectable, we're not going to transmit to our sexual partners. And it's really an essential component of ending the HIV epidemic by getting people tested, and they're more likely to stay on antiretroviral therapy. Next. And does U=U mean zero risk? No, it does not. It helps me achieve and maintain a viral, undetectable viral load. But when persons stop their antiretroviral therapy, it's going to lead to viral rebound, which then will lead to an increased risk of transmission. So success really depends on programs that can help people remain in care and address barriers to being adherent to their antiretroviral therapy. Next. Let's see, these are clinical trials that are specific to women. The longest one is the Women's Interagency HIV Study. Multi-center, this has been going on since October of 1994. Just investigating the impact of HIV on clinical, laboratory, and psychosocial effects in women. You can see what the purpose is to collect data and provide support for women who are currently infected or who are at risk for HIV. This is the population, and this is currently ongoing, and I don't see an end to this study ever. But it is not currently recruiting. Next. The AIDS clinical trial group 076, that was in the past, was related to women who were pregnant being put on an antiretroviral to see if it would help decrease mother-to-child transmission. And it did, and it really, you know, the outcomes that they were seeing at weeks during this trial were outstanding, and they had to stop it and put all the women on the antiretroviral because it would have been negligent not to do so. So there are many trials on a global level that are specific for females and HIV, especially in Africa, where infection rate continues to if not rise, stay stagnant as it has. Next. And another trial reversing the epidemic in Africa with choices in HIV, looking at oral PrEP plus a vaginal ring. It's looking at enrolling 300 girls and young women. And the ring actually has davirapine in it, which is one of the antiretrovirals that we use for therapy. And then using PrEP, which is Truvada, on a daily basis. So this ring that's inserted into the vaginal canal plus the use of PrEP is this study. Next, please. And go ahead. So if anybody has any questions or any comments, I'd love to hear them. And remember that if you have any questions about HIV, need some education, just pop me off an email. I'd love to hear from you. Thanks, everybody.
Thank you so much, Carolyn. That's a great presentation and super important to share with a wider group of people. So I'm glad we're this as always, so some more folks can watch it on their own time as well. But thank you.
Awesome. Thank you.
Did anyone have any questions or comments that they wanted to discuss with the group?
Thanks, Carolyn. Thank you so much, as always, for doing a great presentation.
Thanks, Kaylee.
Yeah, you're awesome. I was going to ask, well, I had one comment about the prep. I can maybe give a couple suggestions on the prep portion, but I also wanted to ask, I know you were doing some talks with the Positive Health group on pronouns and transgender care. Would you be able to do a didactic for us here with the program on that too?
Please let me do one.
Really? Okay, I would love
yes.
that. I'm not able to join in on the Positive Health, but I think that's something that we also need your expertise on. So if you're able to.
Oh my gosh. Thank you for saying that, because we think that is so important. And Sarah and I actually worked on that. And we have, Mithra, I already have a slide set prepared for that. And it took us, I'd say maybe 20 minutes or 30 minutes to do that for the Positive Health Clinic. But for anybody that's still on, we have a really large trans adolescent population. It's the largest in the state in or the largest in the country in West Virginia. And so this didactic is a very, very basic educational piece, starting out with pronouns, why you would use them. And Sarah and I actually got some help from one of her friends who lives in London. We did a Zoom meeting to make sure that that our words were right. And that the message that we were trying to get across was right as well. And so he gave us the thumbs up. And then Sarah had the bright idea to purchase some lapel pins. See my lapel? That said, ask me about pronouns. And so I wear mine proudly. I wear one on my clothes and I put one on my purse so that people can see it. And another thing that you can do as well, and I don't think I have, see in my name, I put my pronouns. That's a wonderful thing to do, because that normalizes kind of this. And if you ever felt like you wanted to do that for your Zoom meetings or whatever, other people might notice and maybe they'll start to do that themselves. So anything that we can do for the trans community in West Virginia is a positive, I think. So yay, Kaylee.
Thanks so much. I really would benefit from that. I think that's something that's needed, and I fall short in that piece of my understanding of what the best approach is.
Yeah, and Kaylee, I do too. I have several friends who are trans, and I have made mistakes before. And, Sarah and I are both we're learning along with everyone as we do these. So we felt a little discombobulated, I think, trying to talk about it. But it is so important. So we will be learning along with everybody else.
Well, thank you so much. I appreciate that. The only comment that I had, about your whole talk was great, but the only thing I can comment on would be prep, because that's my area. But one of the things that I would mention, just kind of to help increase uptake, or at least getting that knowledge out there with our primary care docs, when you're doing your well woman's visit, or anytime that you have, even when you're first getting that sexual history, go ahead and bring it up and just say, anytime you get a new partner, or whenever you're having you're getting your well woman's visit, just say, hey, this is something that we offer. It's for HIV prevention. If you feel like you'd benefit from it, we can certainly talk about it further. Or even as part of your routine STI screenings, you can just mention, hey, PrEP is a thing, and then kind of start that conversation as far as sexual history, or see if they're interested. And then kind of my analogy with PrEP is that I feel like appeals to my female group is just saying, you know, it's like birth control, but instead of pregnancy prevention, it's for HIV prevention. And so that's something that kind of sticks a little bit more with some patients. And then a lot of our echo providers on the call, they also prescribe medication assisted therapy. And so with that injection risk factor, certainly, you know, sometimes they go hand in hand, but that might be a way to approach it too, is how, even though you're in recovery, you know, this is something that you could still be at risk for. And even from that approach too is breaching that PrEP discussion. So, but thank you so much for everything.
I'm sorry,
as
I have
always.
a phone call. I have a phone call.
Absolutely. Thank
Bye.
you so much, Carolyn. We appreciate it. All righty. Well, thank you all so much.
Hello.
We'll take note for the transgender care topic for the future. That's a great idea. So we'll take note of that and look ahead in the schedule, try to squeeze that in because it's such an important topic. The only announcement that I have is that our next session's on July 8th, and Kaylee is going to be discussing HBV, HCV co-infection. So keep an eye out for that reminder. Thank you so much again, Carolyn. We really appreciate your time and that presentation.
No problem. I'm sorry about that. That was a spam call, and I thought it was coming.
Oh, those are the worst. No worries. You're like 10 of those.
Honest to God. Hey, listen.